Welcome to ACO Perspectives. I'm your host, Greg Shockey, and we're here today with David Salazar of Genuine Health. And David, tell us a little bit about yourself and what you're doing with value-based care.
Thank you, Greg. Pleasure being here. Thank you for having me. Well, my current role is Regional Vice President of Genuine Health for the growth side. I'm responsible for growing the business. We are a strategic growth organization. We look at performance, weigh performance more than just attribution and just growth in every market. We have particular MSAs we focus on. We're in South Florida, we're in Tampa, Orlando, all the Treasure Coast of Florida as well. We're currently in Texas, which is our fastest growing market. We've been in there for a couple years. We're also in South Carolina. We're expanding to Georgia, possibly Tennessee and Missouri. But I follow opportunities, right? If there's enough, attribution, there's enough, physicians in a particular state, we will definitely, grow into those states. Where are we different than most ACOs? Our philosophy is boots on the ground. We believe in growing within the market. We hire within that market. So I have growth reps in, San Antonio, Houston, Dallas, Austin, all the areas of Texas, as well as all through South Florida, Dade, Broward, Palm Beach. We have reps in Jacksonville that also work our Georgia market. We have reps in Tampa. We also have reps in Orlando as well. Been with Genuine now in April will be 8 years. Been in value-based care longer than I'd like to admit. Started in 1997 on the health plan side. On the medical side of things, did from institutionalized tracking to grievance and appeals, authorizations, worked at an emergency hotline. Then I was fortunate enough to, through an HMO, start network development, and I really feel like I found my calling, my niche. After I left the HMO world, I started my own MSO. We did that for about a couple years with 4 partners. I really wanted to dedicate on the primary care side. They went into the specialty side. Then I started my second MSO with my partner, Bruno Suarez, which we sold to Genuine in 2018. So we stayed on in leadership roles as well as stockholders in the company. So I'm that growth rep that really looks at performance. I understand the A to Z's into the company. Didn't get into the ACO model until we were purchased, to be honest with you.
Okay.
MA, health plans, independent physicians under my MSO, and then kind of knew of the ACO. I knew it kind of buzzed around and I knew the word, but really didn't know the details. Got very intrigued when we started with Genuine Healthcare. So we started with an acquisition of an ACO, a new entrance where attribution mattered more than actual performance. That's when you had a lot of specialists that had your attribution. Then we carved out, got into the primary care side of it. We were one of the first 53 for the direct, model that eventually became the reach model as well. So currently our company, we manage close to, I would say, north of 65,000 Medicare lives between MA and our ACO product. We only deal with independent physicians. We do not own brick and mortar. We're not affiliated with, hospital-based kind of affiliations. It's really independent physicians. So we exist so they can continue to exist. They're not forced to kind of adjust to the value-based component or, sell to a hospital just to survive with all the things and the strenuous things that are going on in the marketplace. Really excited about the new programs. I think it really shows and signals that we are headed towards that value base, right? That our CMS believes in it, the government believes in it, and I think it is the future. The new LEAD model is a 10-year model. It's no longer a pilot as REACH was, and now you have the ACCESS model, which pushes towards that value-based component as well. So like I was telling you earlier, Greg, I think we all took it on the chin. Anyone who had risk models, anyone in value-based for 24, 25, we had hard, difficult years. But we were able to kind of sustain it and come out to the other side. So we're really excited with these new programs. I think they'll be beneficial. I think there'll be additional economics for our providers because I believe primary care needs additional revenue to survive at this point. So we're really excited what, the next 10, 20, 30 years may hold on the value-based space.
Well, you bring up a lot of the new models that CMS has, and I think this is really an exciting time in healthcare with there's Maha Elevate, there's Access, there's LEAD, there's Teams, there's Guide, the alphabet soup it's become with CMS in the last few months that they've released all these exciting models. But it's a very exciting time. And with that, I'm sure there's going to be a lot of opportunities, and there'll probably be a lot of challenges as well. What do you see as some of the, you were kind of mentioning some of the opportunities, what are maybe some of the challenges?
Well, the challenge is the new programs, right? As we talk here today, we really don't know the details behind Access. We know a lot of it. I know you and myself talk about all the research we do on the plane ride over from Miami over here to beautiful New Orleans. I was studying and reading and trying to get as much information as possible. I think the unknown, I think the rush to go to market through some of these companies of Access might cause confusion. On the ACO side, as we discussed, and I discussed yesterday with one of my colleagues, is do we play offense or defense, right? Do we go out there and create the Access model and be a direct part of it, or do we play defense? I think ACOs will use it to gain access to primary care physicians that might have relationships with ACOs. You look at that perspective. You look at the confusion for the primary care, smaller rule. Do they have the technology to keep up, with Access and what the models are? Is it a one, all-in-one group that's going to come in and do everything for the provider? Or is it going to be pieced apart by 5 or 6? So now you have 5 or 6 different people coming into a small primary care office, which will lead to confusion. Are we taking away the care from the primary? Are we duplicating services? The part that makes me nervous is that a patient can contact the Access directly, which kind of bypasses the primary care physician. So those are some of the concerns, as well as the excitement from the program. I think it reiterates value-based care. It shows where the future is headed. We've been telling this to our providers for 20 years. It's coming, it's coming, it's coming. Well, guys, it's here. So I'm excited about the opportunity. I'm excited of the engagement that providers are going to have, and everything seems that it is kind of the same message being given out through different product lines, whether it be an MA product line or now through the Access and the new LEAD model. I think it's really pushing everyone towards that value-based care.
Now I realize it's extremely early. We just got the RFA for Access, and applications are open. It'll close in April and begin in July. And then the LEAD they've announced, but we don't yet have the RFA for that yet. But, and I just put out an article on my newsletter with reading the tea leaves, when you're talking about reading the tea leaves there. I'm curious what your perception is of, how many entities will be involved with this? How prevalent will this be in the ACO landscape? And, what kind of a role is this going to play in terms of market competitiveness and where it might go and what ACOs should be doing in that regard, or any of those topics if you'd like to.
Yeah, absolutely. So we're an ACO that we have an MSSP flex. We have a reach model. So, in the South Florida market, capitation is big, but as I've gone into other markets, even Tampa, Orlando, Texas, fee-for-service is really where their mind is at, right? So how do you incorporate the managing of value-based care as well as, capitation or enhanced fee-for-service? I think the model LEAD is pushing the positive of the MSSP. I think there were some negatives with REACH, between benchmarking and, certain aspects of the program. You came out and offered cap at first. Fee-for-service run rate was significantly less than what you're paying on a capitation. I think that affected a lot of ACOs financially, so they kind of pulled back, including ourselves, into more of an enhanced fee-for-service when we were promoting the REACH. I think this gets us excited again for the program. I think they've made a lot of positive changes in the sense where the forgotten primary care physician that might have joined an ACO years ago was not successful and was kind of thrown to the side, right? Because you have to take a risk with these providers. You have a very short runway of 1 year starting, and then you have the downside. So a lot of these providers were either forgotten or put on, a basic level A program with very little, very little upside when you look at the big picture, right? So we always believe that flex gives us additional economics. We do performance-based rewards, and we're looking to do something with LEAD as things, start coming out, and then there's a lot more clarity on the program itself. But we're excited because it's reiterating our mission on value-based care and rewarding physicians for performance.
Let me ask you this question. There, obviously, we do have the RFA now for access. We do not have the rates. What is your perception? And granted, nobody knows, or at least nobody on this side of the CMS table knows. What do you think? Are they going to be attractive? Do you think they'll be sufficient to enlist a lot of excitement in the model, or not?
So that's the $1 million question, right? If the economics aren't there, you're not going to get a small independent practice to really focus on these programs. So the economics have to be there. I'm not saying ridiculous economics where it's not sustainable, but it has to be enough to get the primary care's attention. It has to be enough to get the access providers, the technology, the chronic care management. There's economics to just creating those programs and maintaining. We have our own internal chronic care and transition of care programs that have been very successful for our company. They're all outcome based, but there's challenges to even get our doctors to engage in these programs, right? So that's where our incentive, our reward, our performance rewards come in to kind of get them motivated to see the dollars prior to any type of shared savings. So I would say the economics need to be there to get their attention. If not, it's going to be a very, very tough program to sell.
Yep. Now back to LEAD. I know we don't even have the RFA yet, so we've got basically the program announcements and a little bit of frequently asked questions that they put out there. Who do you foresee will be interested in LEAD? Do you think this will be mostly ACO REACH programs? I think that's an obvious one there. High needs, new entrant, standard, MSSP, et cetera. Who do you think, rural, new, who would you say would be the most likely?
I mean, low-lying fruit, right, is always the REACH provider. Yeah. They're used to that program. They've been in that program, with us for a long time, but we have to resell. It's really not a retention play. We have to go out there to our REACH providers and explain the LEAD and the benefits of the LEAD. We've had over the years kind of what we call a step-up program, where we've started in a basic, then we've advanced to an enhanced, and then ultimately to a REACH model. Something similar where there's more of an upside for the provider. I think LEAD, based on what I'm reading, could supply that, where you're not going to the basic, then the enhanced, and then jumping into the LEAD, right? There's a lot less financial risk, I think, for the ACOs, which REACH, you always had to really evaluate and underwrite the provider that you were bringing in, especially with a sizable panel, right? So a lot of those were put on different programs just on the sense of protection for the ACO, as you need a couple of years to kind of go through and manage. I think the fact that they're really emphasizing the 10 years is understanding you cannot manage risk year to year. If a provider changes or, an ACO is eliminating their providers, there has to be way more runway to be successful in this, right? You have to code patients. They have to get used to, kind of all the things we have to do on the quality side, the frequency of visits versus fee for service, and now into these models. And in smaller practices, they're kind of set in their ways, right? Sure. So, I always make the analogy, I'm the uncle, not the father. So relationships matter, how you kind of incorporate yourself to the everyday working of a smaller office or a mid-size or even a larger office. You don't want to come in and impose your will. You kind of want to see the way they do things and where you can be a value added into their processes. We do a lot of the back office for them, and like I say, our engagement is not just through a growth officer or provider performance. It's our quality. They're assigned a quality rep, they're assigned an MRA coder, they're assigned a performance rep and a growth rep who closes the deal and brings the business in. So there's a lot of touches that we do in each of these practices. And even with that, again, the engagement, it's always a challenge, right? How do you get them to focus on the importance, especially when, let's say 70% of their practice is commercial based, right? And now you're coming in on a Medicare side when they're kind of doing things on the commercial side. That's why these programs excite me, because not only is Medicare pushing this on the, what we call the free Medicare is known as the fee for service around, all of the other states, but in the South Florida world, we always called, Medicare without an HMO free Medicare, right? But now you're seeing commercial plans, you're seeing quality incentives, you're seeing chronic care management within their commercial policies. So these are things that you can kind of educate the providers on, that every contract that they have internally within their practice are leaning in the same direction. You're not kind of fighting the message. So that's what excites me. That's where I don't want to say I told you so to my providers, but I kind of wink at them and I'm like, yeah, I told you this day was coming, and it's actually here. So I think it's an exciting time for us in the value-based care, in the risk space. I think risk is going to give providers more opportunity to see revenue. But again, there's some work that comes with it. It's not an easy, one size fit all. It's not a technology base. There's an education process. We go in and educate, not only the providers, we educate the staff, we educate, the MAs, the PAs on why we need the things we're asking for, right? Why are you looking at a suspect list? Why are we closing gaps? Why do you need to bring that patient back in? And ultimately it leads to better healthcare and better outcomes for the patient. The fact that we're incentivizing a patient to be healthier, right? There's certain incentives within the LEAD program that I think point towards that direction. Again, I thought, wow, 65 was a long way away. It's 12 years away from me now, right? So the 65-year-old of yesterday isn't our 65-year-old today, right? They're very active. They play golf, they're at the gym. So giving them incentives to stay healthy through these programs, I think are another kind of, key to the process, because it can't just be the ACO, the provider, the patients have to play a role in their healthcare as well. So I think all these programs are kind of pushing in that direction, and I think these are very exciting times.
So you've talked around the edges of all this. What role do you think technology will play in both ACCESS and LEAD? Obviously, it's a big part of ACCESS, but in LEAD as well.
Absolutely. I think healthcare, we're behind in technology. I think we still have flip phones and Blackberries, if you want to use an analogy. And I think technology with communication, the sharing of data, I think, through companies like Health Endeavors and other companies, it's easier to do actual underwriting and look at performance. For providers, I think we've advanced over the last couple of years. I think we're still behind, and it's exciting because I think the sharing of information and data between hospital, specialists, diagnostic, lab, and primary is the key to this process. And I think emphasizing that technology is going to give us that information that ultimately could be shared, with all the caregivers for a particular patient. I think we lack that today. It's very easy to call an Uber, but it's really hard to get your lab results on your phone. So those are the things I think that these programs and the push for technology are going to advance us rapidly to get maybe 10 years, behind the technology instead of 30 years. I think that's the crucial part. Again, there's a lot of technology companies, as we talked about, that put a lot of money, create these platforms, and have no idea what value-based care is, mechanism of payments. They think one patient is all the same. They don't understand the MA versus, the fee-for-service Medicare. I think that's going to present challenges. But ultimately, it's really going to get the provider's attention, especially with CMS pushing the technology component. I think it's something we're lacking, and we need it, and we need to take advantage of it.
Well, any final words, parting thoughts?
I would say I'm really excited, for what the future is going to hold on the value base. But I'm also very curious to kind of see, how everything pans out. We have a little more understanding on ACCESS. I would love to see the economics. I'd love to get more information on the LEAD and ultimately see the economics behind the LEAD program as well. But look, MSSP has been very successful as well, so I don't want to discount those programs because there's new programs out there. But again, everything's leaning towards that value-based, risk model which I think is definitely the future, and it's here to stay.
Well, thank you so much for joining us. I appreciate you taking your time out to spend a little time and share your thoughts on this. And we're so thrilled to hear your perspective on where value-based care is going and the new ACO opportunities for the decade ahead.
Absolutely.
So
Thank you,
so much.
Greg. Thank you for having me. Appreciate it.
Appreciate it. Thank you.
You.